All right, hey guys. As you may have seen, this PowerPoint has been updated a little bit from the one that was originally there. If you have the original PowerPoint, you can still use it. That's no problem. I just feel like the flow was a little illogical, so I changed a few things. So first off, we're going to talk a little bit about the nervous system, and it is broken down into two systems, the central nervous system and the peripheral nervous system. The central nervous system is made up exclusively of the brain and the spinal cord, where the PNS, or the peripheral nervous system, is made up of the nerves that are transferring that information from place to place. So when we break down and see what makes up each of those individual systems, we have neurons or neuroglia. And neurons are unipolar, bipolar, or multipolar. And what that just means is that there is one, two, or many dendrites on the end of an axon. And when we look at the actual image of a neuron here in just a minute, that'll make a little bit more sense. Neuroglia are smaller particles that are primary role is in creation and protection of that neurologic system. And it's broken down into several pieces, which is the first, the oligodendrocytes, which produce the myelin, and myelin is a covering. And then we have the microglia, which break down other cells. They kind of eat up with the process of phagocytosis. We have astrocytes, which help develop the blood-brain barrier. You guys have heard me talk before about the fact that the pH of the blood and the pH of the brain and the brain tissue is not consistent, and that those really aren't supposed to mix, and that's true. The blood should be in the vessels, not around the brain tissue itself. And so to keep that from happening, we have what's called a blood-brain barrier. It's literally a barrier that keeps things from crossing from one to the other, and astrocytes help with that. And then we have the ependyma, which produce CSF, or cerebrospinal fluid. That fluid surrounds our brain and goes down the spinal column and helps act as a cushion to help keep those safe, since they are essential to our life and function. So neurons. Neurons have a couple of different components to them. First, we have the sensory neurons and then motor neurons, and in between those you have the interneurons. So sensory neurons are afferent. Remember, A comes before E, afferent. They basically sense what you're feeling. So when you reach out and lay your hand on the stove, it's hot. Your brain sends a signal, or that sensation sends a signal up to your brain, where interneurons go, wait a minute, that's hot, you need to move your hand. And then it sends a signal back through efferent, E comes after A, neurons to your hand to say, move away. And so that's kind of the process of the neurons. They feel something, then they send a signal to say, you shouldn't do that. Your brain processes it, sends it back out, and then you respond. It sounds like a very long process, but think about how fast you respond to something when you feel it. So that being said, when we talk about patients who have neuropathy, neuropathy, now some of these words we've used in the past are starting to make a little bit more sense. But when those patients don't have that sensory perception, there's never a signal to their brain, hey, I need to move, hey, I need to get this checked. And so that's why problems can develop for them so much easier. So here we are looking at an actual neuron, and this is a multipolar neuron, and you can tell that because if you see all these little yellow, let me see if I can get a pin up for you guys here. Well, the laser pointer will work. All these little things right here, these little pieces sticking off are called dendrites. And those dendrites are little branches that receive the signals. And so because there's multiple of those, that's how we can tell this is a multipolar neuron. So those are attached to an axon, which is basically what we call the tail. And this tail is covered in these little wraps. And these little wraps are myelin. They're made out of myelin sheath. And myelin is what tells us how fast we respond. So the more myelin on a cell or on a neuron, the faster we respond to that. So when we hear about people who have neuromuscular disorders, maybe they have MS or a Guillain-Barré, they have an interruption or a disruption in the function of the myelin or the myelin sheath. And so therefore, even if they have a sensation, by the time it reaches the brain and says to respond, the body doesn't have enough time to get that signal back down there before kind of it's too late. So maybe they try to stand up and their brain senses, oh, I should put my foot down now based on the pressure. But by the time it sends it to the brain processes and sends it back, it's too late. They've already fallen over. So that's exactly what the myelin does. It determines the speed at which we transfer information. So please take a little bit of time to look over each one of these components, exactly what they do. These little spaces in between, they were used to be called the nodes of Rainier. They've recently been changed to the neurofibril nodes. And those are spaces that are evenly developed between neurons to help transfer that impulse. So now if we think about some of our things that we talked about last week with electrophysiology and all of the electrolytes in our body, the reason it's so important that those function is because they stop between point A and point B, and we have to ensure that that electron has enough charge to allow that nerve impulse to jump that bridge to help continue that process. So coming from the spinal cord, let's look at that just a little bit. So coming from the spinal cord, we have this bony structure here, which is this kind of tannish gray stuff that you see around the front and back. And it has these little holes in it, and these little holes are called foramens. And then inside of all that, you have the actual spinal column, which is created of gray matter and white matter, just like in your brain. And coming off of that, you have all of these nerves. And they're all protected by a little bit of fat and a little bit of cerebrospinal fluid. And those nerves that come off go in different portions depending on where they come out in the spinal column, all the way up at the top or way at the bottom, and they carry signals to specific places. So when we're looking at these components, you see here how you've got one lighter than the other and darker. That's the white matter and gray matter that we talked about. So white matter has a whole lot of myelin in it. That's what helps us process, and so that's going to control a lot of our learning, our cognition, sensory processing, things like that, where the gray matter is going to focus more on sensation, muscle tone, muscle control, things like that. And so if either one of these areas become damaged, say we have a fracture of this bone, well, if it only punctures here and doesn't get into some of the gray matter, your symptomology is going to be different than that as if it goes all the way through or breaks into that white matter. Or if it just tears the nerve, maybe the nerve going to that area is damaged, but other area functions. So that's why it's so specific about where an injury occurs in the spinal column as to what the response is for the patient. So next we have the spinal cord, which is what I was just talking about a little bit about where in the body an injury occurs as to what it does. So this is the one you were looking at before is like you were looking down from the person's head going towards their feet, and now you're looking from the back. And so you can see each section and how it's divided. So here we have the cervical, this little upper portion, cervical spinal column. Then we have the thoracic, which is like we think of chest, thoracic. And then we have lumbar and sacral, which kind of go together, and those run the bottom half. So the cervical equals control of basically everything from the diaphragm up. The thoracic is going to cover the entire abdomen, back, all the way down. And then the lumbar and sacral is covering everything from about the waist or the lower abdomen all the way down to the end of the feet. And so depending on how high an injury is will determine how much function or loss of function a person has. So if a spinal injury is way down here, they may just have some numbness right in this local area. If it's up here, they may lose some control of their feet or legs. The higher it gets, the higher the injury level. So if someone's injured up here, they're probably going to lose function basically at the nipple line. Maybe the arms still work, but they have no function from the nipple line. If we move on up here, this is including the upper extremities, head, neck, shoulders. This is a person who we think of as a quadriplegic. So it really depends on where this injury has occurred as to what impact the patient feels. So reflex arc, this is very similar to what we were talking about how the kind of nerves and senses work, is you sense it in the skin, muscle, tendon, you feel something, And then the afferent neurons or afferent pathway send the signal directly into the brain or the spinal cord, depending on where it is. Then you process that, which is this into a motor neuron. You process it, and then you send it back out to the muscle to respond. So you may contract or it may relax depending on what the stimulus is. So how do all those things go into a component with the brain? So the brain's primarily divided into 4 sections: the cerebrum, the diencephalon, the cerebellum, and the brainstem. So the largest of which is the cerebrum. It is covered by all these little ridges and grooves. And all these little ridges and grooves basically indicate how much surface area there is in the brain. So the amount of surface area that you have in your brain basically determines how much information can I hold. So a really, really wrinkly brain is going to be with someone who has a lot of information. And if you look at somebody maybe with Alzheimer's or who has age-related dementia, their brain, if you could see it, is going to be much smoother. It's going to have a lot less of these folds and these lumps and bumps because there's less need to hold information, so that surface area becomes less and it smooths out. So these ridges, called gyri, are these lumps. And then you have the sulcus or sulci if you're looking at many of them, and that's the groove in between. And so, like I said, that just gives us the area in which to hold information. And so if you see the brain from up above, you would see that there's a line right down the middle that divides them into hemispheres, or one side and the other. And in the middle of those hemispheres, you've got the corpus callosum, which is really just a major network of nerves and fibers that send that information from one side to the other. And the reason that's important is because our brain controls the opposite side of our body. So if you do something with the right hand, the left side of your brain is doing that, or vice versa. So when someone has had a stroke and we go in and see that they have left-sided weakness, that means that the right side of their brain was damaged. So remember that when you're thinking about where an injury occurs and you start making a plan of care, if you see that the person had a right-sided stroke, what are your thoughts going to be for how do I need to manage the care of the patient who now has this left-sided injury? So think about those things. Let's see what else we have. So I talked a little bit about white matter and gray matter in the spinal column, but in the brain, it's the same concept. White matter is on the outside. It's got all that myelin. That's what makes it white, and it has primary focus on neurological cognition, learning, development, and transferring that information, where the gray matter is going to be responsible for function, body function, motor function. So nothing really makes us go, let me put my leg down by moving this muscle, then this muscle, then this muscle. That's what gray matter does for us. It controls those kind of independently. And then we have a couple other portions of the brain here. We've got the diencephalon, the cerebellum, and the brainstem. And so the brainstem is composed of the midbrain, the pons, and the medulla oblongata. So some of you who watched cartoons when you were a kid are probably familiar with those words. But those are at the bottom of the brain, and right as you enter into the brain stem, which continues, or the spinal column, which continues right in this area. And so I think you maybe remember when I was talking to you last week about if the brain swells and it starts to push down, if this is the area that's getting smushed, this is going to make a major impact on our function. And the reason for that is this area is responsible for reflexes. If you feel like you're falling, your body naturally tries to sit itself back up. That's what's responsible for that. Balance, normal breathing, normal heart rate, all of those things are regulated there. And so if we don't have proper care in that area, then we're high risk for respiratory dysfunction, cardiac dysfunction, and death. And next we have the cerebellum. It's just behind the brainstem. It's this funny looking thing. The texture is very different of that of the rest of the brain, and that controls involuntary movement. And so what I mean by that is when you reach for something, again, you don't have to think about which muscle is doing that or anything like that. There's not a twitching or jerking while you're processing it. It's a smooth movement, and that's because this portion controls those involuntary movements, making sure that they're smooth movements, they're coordinated, they're going in the right direction of what you want. And then lastly, we have the diencephalon, which filters input. So we think of kids who have sensory processing issues. A lot of that is going to be related to the diencephalon. And what I mean by that is when we're sitting in the classroom, or right now you're sitting at home and you're listening to this, your spouse is talking, your kids are talking, the clock's ticking, the drink has little bubbles in it because we know I drink soda all day, right? And so little carbonation bubbles make noise. If you just close your eyes and try to listen to every noise you can hear in your house right now, if you didn't have something to filter out those things, we would all go insane. So the diencephalon literally takes and says, what do I need right now? What's most important? And starts to kind of filter out some of those unnecessary things for that moment. And so if we have sensory processing issues, a lot of times that's because maybe we're not censoring out enough of it and we're getting very overwhelmed because there's 12 things coming at us. And so that's part of what the diencephalon does. So if you want to, page 983, look in your book, those areas have a little bit more detail on them. If you have questions about that a little bit more, we're going to talk about each section of the brain from there. But if you have questions, please make sure that you put those on the discussion forum so I can answer them. So the cerebrum, I told you it's the largest portion, and then it is broken down into subsections. You have the frontal lobe, you have the parietal lobe, the occipital lobe, and then the temporal lobe. These are kind of easy for you to remember. Frontal's in the front. Then you have occipital, and the reason I remember that is it's the opposite. It's in the very back. You have the temporal, which we all know what our temples are, so you can remember that goes with your temples. And then the only thing that's left over you can remember to be the parietal lobe, and it kind of sits here in the center and top. So the frontal lobe, which is in the front portion of our head, is responsible for movement of everything that occurs on the opposite side, and then Broca's area of speech, and then our personality. So if someone has a stroke in the front part of their brain, they're more likely to have trouble with their speech. They may be a little bit more irritable and have personality changes. Next, we have the temporal lobe. The temporal lobe has to do with our hearing, our smell, and then Wernicke's area. And Wernicke's area is what recognizes speech. So Broca is taking what you have in your head and spitting it out in words that we can understand. Wernicke is listening to someone talk, putting it in your brain and processing it to see what they mean. And so those are different areas. So think about that when you're caring for your patients. Just because they don't have the ability to get their words out doesn't mean they don't understand everything you're saying. It depends on where that injury occurred. They may be able to speak clearly with their thoughts because they've got that Broca's area intact in the frontal lobe. But then when you talk to them and they give completely erroneous answers that make no sense, that may be because the temporal lobe has been impacted. So remember those things when you're thinking about patient care, that one doesn't necessarily always go with the other because they are controlled in different parts of the brain. Next, we have the parietal lobe, and our primary focus with that is going to be with taste, things that go with aiding in digestion, processing. And then lastly, we have the occipital lobe, which is sight and vision. This is actually interpreting what we see and making sense of it. Some of the other areas of the brain may also look at those nerve functions coming from the eyes, but they don't necessarily turn them into something we can recognize. The occipital lobe actually allows us to recognize that image. So then with cranial nerves, we're on page 985, table 47.1. So the cranial nerves are listed, one being olfactory, optic, and it goes on to give you each one of those and kind of tells you what its function is, what its name is. You guys take a minute. I'm not going to give you a mnemonic personally because there are different ones. Some of them are more effective than others. Type in, cranial nerve mnemonics or whatever on Google, and there's going to be several little things that pop up that you can see which one is going to be best for you to use to learn. But they'll have little sayings like, old orange I don't know what the next O would be. Took Timmy around, something like that. They'll come up with some little acronym that you can remember. There's several different ones, and I don't use any of them because I think about how they function, and that gives me my assessment tool. That's just the way I learn them, and so that's how I've stuck with them. But there's a lot of mnemonics that I've seen people use. So if one of those work for you, please use them. But the cranial nerves are basically nerves that we would use to assess to see what is functioning coming for an individual: smell, sight, their gag reflex, use of muscles, things like that. So can they see? Can they move their eyes? Each nerve has its own function, and we'll talk a little bit more about how to assess each nerve momentarily. But please make sure that you can pause me, look up that, write down some acronym that works for you, so that as we're going through this, you can start memorizing those cranial nerves and which one does what, so you'll be prepared to answer questions about that. So then we kind of break it down into two systems. We have the autonomic nervous system, which is divided into the sympathetic and parasympathetic nervous system, and this is all supported in the hypothalamus. So the sympathetic nervous system is primarily focused on the thoracic and lumbar areas. So remember, we have cervical first, which is here, and then we have the thoracic, lumbar, and then we have sacral here. And so these kind of tell you a little bit about what nerve goes to what organ. So you see here we're talking about liver, stomach, kidney, pancreas, spleen, intestines, and then bladder's kind of down here at the bottom. So looking at this, we can see kind of what things are impacted primarily. That the sympathetic nervous system is driven by fear, anxiety, or stressors. So this is kind of some of that fight or flight that you hear about. And when this occurs, we're going to increase our heart rate. Our blood vessels are going to constrict. We're going to need more oxygen, more sugar. Our body's going to create this norepinephrine and this acetylcholine. We're going to have this rush of hormones, which are going to give us all the energy we need in a fight situation or a flight situation to do something to manage ourselves emergently. So somebody comes out at you go on a haunted trail this weekend because it's getting close to Halloween, right? And the man with the chainsaw comes running at you, and you feel that sudden change, like your heart rate picks up, your stomach gets a little bit queasy, you breathe faster. That is your sympathetic nervous system taking over, and it's telling you run, fight, whatever. And when it does that, it's giving your body the energy it needs to be able to do that successfully. Can we do that long term? Obviously not, but that is our maintenance therapy right there. Then we have the parasympathetic nervous system, which is basically the exact opposite. This is working up there in that cranial section and then at the sacral region. And so it's covering the top and the bottom. It's going to cover more with our bladder. It has certain components of the intestines and kidney, spleen, pancreas again, stomach and liver. But this is also going to significantly impact the heart, the lungs, the eyes, and brain tissue. And so when we start thinking about these components, this is what's going to keep us calm and normal. Something has to regulate our heart rate other than just the electrical impulse. Something's got to send a signal to tell it to speed up and slow down. And that's what the parasympathetic nervous system does. It is the brake check when somebody's on too close to your butt and you're like, I need you to stop now. That's the parasympathetic nervous system. Hey, your heart rate's too high. You need to chill out. That's what it's doing for you, is keeping everything in check. And it tells you a little bit more about which craniofacial nerves that it impacts and how that impacts the system. Like, I think some of this is important because it talks about salivary glands. So it talks about thinking about when you get scared or calm down or whatever, if you get dry mouth, why is that occurring? And you can look at the parasympathetic and sympathetic nervous system and how they respond to figure out some of that. So when we look at aging is a chart on page 989, I believe. Yes, 989. And the short version of this is everything slows down. We have slower rate of transfer of electrons across those synapses. We have less myelination. Our brain starts to smooth out a little bit. We decrease our production of epinephrine, norepinephrine, and dopamine, which are all major functions in the way our brain acts. And so, because of those changes, we end up with decreased mental function, decreased judgment, reasoning, orientation, changes in our sleep patterns, memory loss, motor function loss, and some balance and fall issues. All of those seem pretty reasonable to our assessment, so we're not going to go into much more detail about that. So, now that we know some of the basics about what the components of the body and brain do, let's talk a little bit about how we assess those things to see if they're actually functioning. So the first thing you're going to want to do is obtain a patient history, because before you go off doing a major assessment, I can't remember who it was, one of you in clinical had a patient that had weakness, and you had identified it from a pre-assessment, and then they came back from surgery and somebody was asking a question about it, and you were able to say, maybe it was Andrea's patient that went down for the hip surgery. But you guys had talked about the fact that she had some weakness in that area, and because you'd done what you were supposed to as nurses and done that pre-assessment, you were able to find that. To take their history, if the patient tells you I had a stroke 10 years ago, you're going to expect some minor deficits. Even with PT, maybe their grips are just a little bit off. And it's important isn't even the right word. It is imperative that you know this, because if you don't know this beforehand, how will you identify changes? How will you know that a new injury is occurring? You won't. So obtain that patient history. Level of consciousness next, which includes our orientation. Vital signs, because our brain is what dictates our respiratory rate and our heart rate and our blood pressure, and we need to assess those to determine is our brain functioning adequately. Pupillary responses to light, movement, control, extremity strength and movement, and then sensation. So how are we going to do that? First, get their history, symptoms, medications they're using. Why are medications important? Sometimes medications affect the amount of dopamine or epinephrine and norepinephrine released, which is going to impact the response of the parasympathetic and sympathetic nervous system. Surgical history. If they had a surgery that maybe cut one of those nerves, that's me, I'm that patient. If they have a nerve issue that's been related to a surgical incision, is it going to function the same way? Absolutely not. So family history, did they have a family history of neurologic dysfunction or neurologic disorders like MS, Guillain-Barré, things that you might need to be looking for to be a little bit more hyper aware of those changes? What lifestyle things? And then using your What's Up acronym to talk about when it occurred, how often, aggravating factors, things like that. So when we do the physical assessment and we talk about the level of consciousness, from the patient's going to be anywhere from awake, alert, and 100% with it all the way down to comatose. And who determines if they are alert or comatose, and how do we grade that? So we're going to use something like the GCS or the Glasgow Coma Scale, and that's going to tell us, is this person completely with it, or do they have problems? And so if you go to page 991 in the top left section, we have table 47.4. What it's going to ask you is, when you walk into the room, does the patient look at you? Do you have to call their name to get them to respond? Do they only respond to painful stimulus? Something that I think is important for you is to look up and see what painful stimulus is allowed, because we can't just go in there and cause injury to somebody. So how would you create a painful stimuli to determine if someone was responding to that appropriately? That information is in your textbook, so please look that up and know those so that you can be prepared to answer questions about it. So, or if you do that painful stimulus and their eyes still don't answer, then they're listed as no response. Same thing with verbal response and then movement. Do they converse with you? Do they make noise that makes no sense, or do they just say nothing at all? And then motor response. If you ask them to pick up the glass, can they pick up the glass? Or do they only just say it hurts here? Do they only point to certain areas? Or when you touch something painful, do they just jerk away? And then lastly, do they posture abnormally? So when you look at posturing, there's two different types of posturing that we look at, and it's decorticate and deceribate. And so decorticate is bringing everything into your core. Decorticate, bringing everything into your core. So you notice that the wrist, fingers, everything's kind of rotated in. They're brought up to the chest. That usually will only last for a few seconds immediately following head injury. But if the head injury is severe enough that it's caused permanent damage to the brain, that posturing can continue. If they are deceribate, their arms are going to go out. Miss Washburn was one of my nursing instructors, and I will never forget her standing at the front of class saying, "Celebrate," and making her arms go all the way out from her body. And deceribate is when the arms are going to go out. Sometimes it's straight out to the side, sometimes it's straight out in front like this, sometimes it's over the head, but the arms are out and the wrists are kind of flexed and everything starts to rotate in. It's not bringing it up here. The wrist is flexed while the arm is straight. And so that's a little bit different. So from now on, you guys are never going to watch a football game or boxing or anything else the same. You're never going to watch soccer the same because there's probably more head injuries in soccer than anything. But I've got a couple of clips here I want you to watch and see these videos. And then if just for your entertainment, Google it or YouTube it and then find a couple of videos that are entertaining and try to determine if the patient is having decorticate or deceribate posturing based on what happens to their body immediately after a head injury. Let me get my clicker back on. All right, so this is like a week ago. This was last week's Steelers game, I think. So let's watch and see what he does after getting hit and notice where the helmet-to-helmet contact is because it's going to give you an indication of which portion of his brain got hit. Look at his fingers and how his fingers are still pointing like they're drawn up and the wrist is pulling in. And notice that he got hit right at the back of the head at the brain stem. And then on the next one here, let's see what this guy, this is a little bit older video, so it's a little bit grainy, but watch what he does in response to an injury. All right, so look at his body, arms to the chest, brought into the core, and now his brain is still functioning even though he doesn't know what's going on. One side is still and the other side is there. So does that give us a little bit of information, not just about the type of posturing, but which side of the brain was impacted, of course. What else do we have here? All right, so mental status. So we've kind of established their level of consciousness. We know how to look at their posturing to see is this normal, abnormal, what type, how severe, so that we can use that Glasgow Coma scale to evaluate that. Now, am I going to give you a question and tell you this person responds to painful stimuli, has, internal rotation for posturing, and no response to verbal stimuli, and expect you to be able to give me a score? Absolutely not. I don't remember all the scores. I don't expect you to. It's a tool. You check the box and then add up the scores. But what I do expect from you is to be able to know at what level of scoring should you be eliciting help of others for concern. So a 15 is a normal score. That's what we all should be able to do. We should open our eyes spontaneously, have a normal conversation, and obey commands. That's what we want. If someone scores a 13 or a 14, that means they've got some mild neurologic issues, which is going to be things like maybe they just feel the pain, they point out the pain, but they're not aware enough of their surroundings to be able to talk to you and have a fluid conversation. Or maybe they're confused, and so they're having a little bit of trouble from age-related changes. So some of those things are mild, but they're not necessarily a response that needs immediate attention of others. Then we have 9 through 12, which is indicative of severe problems that may need some support. 8 is major and needs help right away. And 7 is someone who is comatose and is going to require mechanical ventilation to keep them breathing. So think about those things. So then we've got a person who is alert, they're responding to pain, and they're following commands. Maybe a little bit confused, but they're following commands. So now we want to assess their mental status. We know what their their alertness is, but now let's set their orientation. So when you guys are writing A and O times 3, A and O times 4, what are you actually writing? So now your answers for that A might change a little bit. Maybe your person's not completely alert. And let's talk about orientation. So 3 are standard for every patient, 4 is best practice. So person, place, and time are always mandatory, and then situation is best practice. So you're going to ask them, you know, what's your name? Where are you? What day is it? And remember, I don't know the date right now. Like literally, I'm trying to look at my computer or my phone, see if I see it. I don't know the date. I know it's Sunday. So ask those questions about what is the day, and don't expect necessarily someone to give you a number value. That might be an unrealistic expectation. And then situation, why are you here? And a patient who can give you information about, I came in because I fell at home, great. They know what's going on. Sometimes I have no idea. I was at home yesterday and then I woke up and I was here. So situational awareness can be a little bit of an issue. So when you're documenting that, alert and oriented, maybe alert and oriented times 3, not oriented to situation, things like that. So let us know where they're getting so confused. And why that's important is because if the next person has consistent findings and then all of a sudden they're no longer alert to place situation, something's changing there. So make sure you keep up with that. If a person has expressive aphasia, meaning they can't get their words out, what area of the brain is that's been impacted? So usually that's going to be Broca's, and where is that going to be? So think about that. If they have expressive aphasia, maybe they can't get their words out, but they can hear you and understand and think exactly what you're saying. So ask yes or no questions so that they can either nod or give you something, and that way you can assess orientation. Are you in the grocery store? No, they're going to know that they're at the hospital. Some people, one thing to be careful with if you're doing an assessment on a patient in a nursing home, if you ask them, are you at home? They may say yes because that is where they live. So be careful about those questions, making sure that if you give a yes/no option or ask where they are, that you're aware that they may have a little different perception of what is home than you do. And then lastly, we can use the CAM, or the confusion assessment method. And that is a tool just to diagnose delirium, because patients can come into the hospital and have all their orientation perfectly intact, and within a few days, they have completely lost it. And a lot of times that's related to the exposure in the hospital. They've changed their scenery, we've medicated them, we've changed their day and night pattern because we're coming in and waking them up at 3 a.m. for tests. All these things can mess with their brain to the point where they become delirious. And so the CAM is a tool to help monitor for that, so that if we identify that someone is starting to become delirious, maybe we can perform some interventions to prevent that from getting worse, to help maintain that orientation and cognition, so that when we discharge them, we're able to discharge them home instead of to a rehab facility when it was just because of environmental changes that occurred. So the next thing we're going to assess is their pupils. Pupils, when we write, so you guys, some of you have already been writing Perla, some of you haven't, but you're going to do it now because you know what it is. So Perla, pupils are equal, round, reactive to light, and accommodation. So round, everybody's pupil should be a circle. Sometimes you will find one that's like a weird oval looking thing. If that is occurring, that is not a normal finding. Sorry, I'm at my dad's, so you can hear his clocks going off. That is not a normal finding, so please be aware of that. So equal and round, and by equal we mean when I shine a light, do they both move equally? Are they equal to start with? Are they both, small or large? Are they equal, and do they respond equally? So when I shine that light, are they reactive? Do they change? Does one change or both? Accommodation is going to be movement. So if I ask you to look over here, do both eyes move, or do one eye only move? Now, some of you have heard the term lazy eye. That's not necessarily the appropriate term, but that's what people commonly refer to it, is when one eye moves and the other doesn't. So if someone has a long-term history or we're born with decreased muscle control over one eye or the other, obviously we cannot use that as a deciding factor in neurologic function because that may have more to do with the musculature. So asking that patient in that detailed history that you collected a few minutes ago is going to give you better answers about that function so that you'll know if that's a new occurrence or if that's part of that patient's baseline. And so if that's a new occurrence, that requires medical management. But if that's their baseline due to muscle function or visual changes, then that's nothing to alert anyone about, but document and make sure that you're aware of so that as you're continuing to perform those neurologic assessments, you can stay on track. Because I'm going to pause for just a minute and I will be right back to you. Okay. So one thing I do want to say for those of you who may be looking at it after the posturing and the Glasgow Coma Scale stuff on page 992, there was a little chart about an assessment. That assessment is only used for patients who are on a ventilator, and we're not currently going to be caring for patients on a ventilator, so I have chosen to bypass that. I don't feel like it's necessarily appropriate for the care that we're providing for patients, and I would rather you spend more time focusing on things that we're actively using in care than something that you're not going to use unless you go to a specialty area, at which point you can learn that when you go back to your bridge program because you're all going to become RNs after this. So, muscle function assessment. When you go in to assess a patient, some of you have been documenting a few of these things because we've been doing them a little bit, but we're going to get into more detail about expectations of your assessment of someone's muscle tone. So when you assess the person's upper extremities, what you may have been having them do at this point was just simply squeeze my hands or something like that, but there's a little bit more detail there. So the first thing you're going to assess is like the deltoid muscle. And to do that, you're going to have the patient lift their arm up at a 90-degree angle to their body, which I don't know if I can do and y'all still see me. You're going to put your hand here and have them raise against you, and you're going to measure the strength that they have to do that. And then you can also assess the trapezius muscles in the same way. Push down on their shoulder and have them shrug their shoulders up. And you're going to do both shoulders at the same time so you can feel, do they both move equally or does one move more than the other? And you're going to do that to the shoulders and the deltoids. Next, you're going to move on to like the biceps. So you're going to have them flex their arms with their palm towards their face like this. See how my arm is at a 90-degree angle? You're going to put it like this with their palm to their face. And then you're going to hold like at the wrist and have them pull their hand towards their face and see how much resistance they have against pulling against you. And then you're going to have them push out, which is assessing the tricep. You're going to put your hand on the backside and push and see how hard they push against you. So you've assessed triceps, biceps, deltoids, trapezius. You've assessed all of these upper extremity muscles. Then you can go down and have them do a couple little things like pinch your fingers just to make sure that they have that nerve touch there. Flexion and extension of the wrist. You can have them push against your hand. So here they are, and they're going to push you. And then you can have them lift up against my fingers so you can feel that resistance there. And then lastly, you're going to have them squeeze your fingers. Some of you who have these nice little delicate fingers, the first time you go put your hands in there and have a confused person and say, squeeze my fingers, you're going to feel like your fingers break. So to keep that from happening, crisscross your fingers like this. And then when they squeeze them, it hurts, but it never puts pressure on bone against bone, so it's less painful. The other thing that I recommend you do is crisscross your arms when you're doing the assessment. And the reason I say that is then what you feel on the right is the patient's right, and what you feel on the left is the patient's left. So otherwise you have to remember to switch it. If you are so oriented to be able to put your hand there and remember, that's awesome. Y'all know I struggle with things. So for me, it's easier to crisscross my hands because then if they squeeze hard on my right and weak on my left, I know their right is strong and their left is weak. Where if you don't crisscross your hands, it's opposite. So do what works best for you. But over the next week, you guys need to be practicing these assessment skills on your friends, on your kids, on your mamas, on your daddies, on your neighbors. I don't really care who, but you need to practice these on somebody so that you can implement them in clinical and be evaluated on those. And when you do that, try some different ways and see what works best for you. Is it crisscrossing? Is it not? So we've covered most of the upper extremities. So let's go down to the lower extremities. So we can't do every lower extremity assessment on every patient. Couple reasons. Some of the lower extremity assessments require having a patient lay on their stomach. Think about that. Not happening for 95% of our patients, maybe 99% of our patients. There are some things, however, that we can do for every patient that has two lower extremities. So one of the first things you're going to do is when the patient is either sitting on the side of the bed with their legs over the edge or sitting up in a chair so that their legs are at 90 degrees, you're going to put your hands on the thighs, on the top of their thighs above their knees, and ask them to lift their legs straight up in the air. You're assessing gluteal muscles, hip flexion, seeing how much can they lift against that pressure. You're going to put your hands on the outside of their knees and kind of sandwich, and then ask them to spread their legs and see can they push you. Put your hands on the inside of the knees with the legs apart and ask them to bring them together and see how strong they are so you can assess adductor and abductor muscles. Then lastly, we're going to go down and put our hands around their ankles and push them towards kind of backwards and ask them to kick out, push out, and see are they able to push your hands away, or put them on the back of the ankles and kind of pull them towards you and ask them to bring their legs back down, how much strength they have there. And then the last thing that we do, which we do on every patient that has two extremities, no matter what, even if they're on strict bed rest, is that plantar flexion and extension. And so you're going to put your hand on the sole of their feet and ask them to push against you, and then put your hand on the top of their foot and ask them to lift their toes up against you to see how strong they have there. So that's something we're going to do on every patient. We'll practice this skill as a group in class on Tuesday after your endocrine lecture. So I hope you've had a time to at least try these things, but we'll do this as a group just so everybody can see the process from beginning to end and make sure that you have all of those skills covered. Next, we have Babinski's. Babinski is a reflex that is normal in children 6 months and under. It's not something that we expect to see as a positive result in adults. And so the Babinski, you can do it with an ink pen, pretty much anything that you want. If you have, a little bit of a nail maybe on your thumb, you can do it, but use your ink pen, use your pen light, whatever's in your pocket. You're going to put that at the kind of the bottom outside of the heel. You're going to draw a line up the foot and then kind of over the toes. So it's going to be this shape, up and over, following the curve of the outside edge of the foot. What you should see is the big toe should kind of curl in, like flex a little bit. An abnormal finding would be this like splaying of the toes. And actually, I'll probably add a Babinski video for you on newborn versus adult so you can see what the difference is. That is an abnormal finding. If you see that fanning of the toes, that tells you that there is a neurologic anomaly that's occurring and it should require further investigation. And then lastly, we have the Romberg test. Romberg is not something that we typically perform in the hospital unless we are specifically doing a neurological assessment, and here's why. It's a safety concern. The Romberg test asks you to have somebody stand up, put their feet together, arms down by their side, and close their eyes and stand there with their eyes closed for 20 seconds and not fall and not tip over and not get wobbly. It's difficult to do, and for an added measure of difficulty, depending on the age of the person you're testing, you may even kind of like push them on the shoulder a little bit to see if they have the ability to right themselves after that occurs. So not something we're going to typically do in an older person because A, they lose balance anyway, so let's go back to that chart on aging. B, if something goes wrong with that test, their risk for fall and their risk for injury associated with said fall is significantly higher than if someone is a little bit younger or healthier. And then 3, it's a little bit of a liability for you. You may see the physical therapist personnel perform this test, but when they're doing it, they have that extra person with them, and they are specifically trained on managing the care of that patient in that situation. So you're typically not going to perform a Romberg, but you do need to be familiar with it, because if you have a patient who has had a stroke or has had a change in their neurologic status, one of the things that they're probably going to ask you to do is perform a Romberg, because that's assessing the severity of the illness to determine what kind of diagnostic test they need to use to proceed. So please be aware of it, even though you're not going to do it on everybody, have at least a functional awareness of that. All right, so table 47.5 is going to be on page 995, the top box, data collection related to cranial nerve function. So we just talked a minute ago about cranial nerves. So how do we test each nerve? This is your responsibility for learning. I'm going to talk about some of it briefly, but this is going to be yours. So talking about each nerve, things that you may ask the patient to do. As you read this, you're going to realize almost every time you went to the doctor as a kid or even as an adult, most of these things occurred, but you didn't realize what they were testing. They just happened. Like stick your tongue out, say ah, smile, turn your head to one side or the other, how many fingers am I holding, these kind of things. So, and you see kids assessments include them all the time, like close your eyes and touch your nose. These are things that they do a lot with children because they're assessing, are they developing neurologically the way they should. So you are responsible for learning this. When, what tests do you do and what does it go with? That's on you. That being said, again, there's acronyms, there's little mnemonics that may help you learn those a little bit easier. So review those. If you guys want to share one that you've got, if you want to email it to me, I'll be happy to set it up in the discussion forum post or in a wiki where you guys can comment on it. That's no problem. But when do we do this exam? Why do we need to follow this detailed and logical order, ensuring that we cover each cranial nerve? So in the hospital, some of you have had the privilege of seeing Dr. Fryman, and I do call it a privilege. I know she's a little bit different, but she's extremely intelligent. She's an excellent physician. So some of you have had the privilege of seeing her, some of you have not. Dr. Fryman is the primary neurologist for the hospital. She cannot be there 24 hours a day, 7 days a week, obviously. So because neurologists are not as common and readily available, we have something called teleneuro. And teleneuro is basically a computer that has a camera and some other devices mounted to it. And you wheel it in, and just like I'm talking to you right now, the doctor's there. And you perform an assessment based on what he wants. He watches your assessment, watches the patient's response, and creates a diagnosis. So for you to be able to perform and function as the nurse caring for the patient in this setting, you have to know what you're doing. You have to know how to perform these assessments. So please familiarize yourself with them, know them. If those assessment findings indicate a problem, then they're going to do something called a code stroke. And that is going to get everybody ready, get the CT machines or the MRI machines cleared, get somebody from neurology actually on the way, get medicines ready, get labs ready. It's going to get everybody ready. So your role is essential in providing that. So please make sure that you familiarize yourself with this and can do that as appropriate. So that being said, based on our assessment findings, we may have a need to perform some diagnostic testing. If you notice, it talks about lab testing, and there's like 4,000 things listed. If you have the old PowerPoint, that is on there. I removed it for this one for a reason. None of those actually indicate a neurologic problem. You may have a neurologic problem based on the signs and symptoms, and you may find out, oh, it's because my electrolytes are off, or my vitamins are off, or my B12, or I have some kind of syphilis, whatever it is. You can find an answer by doing those, but that's not necessarily something that's in our scope. And more importantly than that, it is so different from patient to patient and symptomology to symptomology as to which test. I do not want you wasting your time on learning about a CBC and a B12 and a thyroid level when those aren't necessarily directly appropriate to what we're doing as the healthcare providers, as nurses. So what we are going to talk about are procedures and scans and imaging and things that we may actually have to participate in preparing the patient for or providing care for following that procedure. The first thing we'll talk about is a lumbar puncture. So lumbar, we just talked about the spine, and we've got this cervical, thoracic, and then lumbar. So lumbar is the region that they're doing this test in, and they're puncture, poking a hole, right? So lumbar puncture. So they're going to go and have this patient sit in a certain position after getting informed consent. Do we obtain the informed consent? No. The physician has to inform the patients. We witness their signature. We participate in that informed consent, but we do not actually consent the patient. That has to be done by the physician, sometimes an NP or a PA who may be providing that care, but it has to be by the providing practitioner. So that being said, we're going to witness their consent, and then we're going to assist them into position, which is going to be this angry cat or letter C. We want them to poke the lower portion or the lumbar portion of their back out as much as they can, because our vertebrae sit on top of each other, right? And when we bend, it gives a little bit more room. And as that space opens, there's a little bit more room for the needle to go in. And so the reason we curve them into this position where everything is in an angry cat or the letter C shape is so that that back is poked out enough that the needle has room to go between the bone structure and get in the space it needs. They may draw some fluid out. They may test the fluid. They may just measure the fluid. But when they do that, they're going to send them back to us, and we've got to take care of them now, right? So somebody poked in a hole in their back, and we talked about the fact that there's cerebrospinal fluid and then there's some blood, but there's a barrier between those and they don't mix. What makes our blood clot? Platelets, fibrinogen. Are those in CSF or are those in blood? Blood. So we just poked that hole into someone's back. How do we make sure that it has time to kind of close up and heal? We're going to maintain bed rest flat on the back for 6 to 8 hours as ordered by the physician. We don't want the patient rolling around, because every time they do, they may open up that little hole a little bit more and allow some of that fluid to come out, which is not what we want. We want to encourage hydration. Why? Well, if we're taking fluids out from that space, and I told you the brain is almost completely made up of water and sugar, we want to give them some back so that they're not drying up if they had to take that fluid for testing. We don't want to leave them with this terrible headache because their brain's all dried out. We need to provide them with fluid so that they can use it like they need to. Monitor the site. Make sure that we don't see some clearish yellow fluid leaking out of it, because if we do, that's a problem. That's an immediate need for intervention, and you need to notify the physician. And then monitor movement, sensation, and presence of a headache. Well, I've already covered the headache. Movement and sensation, we talked about how different areas control different functions. If we poke a hole in one of those areas and accidentally hit a nerve, what can happen? What can happen to that patient's lower extremities or the portion where that nerve was irritated? So we'll need to monitor for feelings in all those areas to make sure that we don't have a problem. Additionally, some of us clot our blood appropriately, and some of us do it a little too much. So if someone makes a big clot or a big hematoma, you've heard me say this a million times, and you're going to hear it a million more times before you graduate, so just accept it and memorize it. You cannot compress a fluid. So if you start smushing on that space by developing this big old hematoma or this big clot in that area, and you smash that, the fluid's not going to smash, but the other soft tissue around it will. And what is that? That soft tissue is the spinal column. Well, we already know that controls our nerves and has our gray matter and our white matter. So if we compress those and damage that, how's that going to impact sensation and movement significantly? That being said, there's one thing that I forgot to mention in assessment. Sensation. The easiest way to assess sensation is to go into the clean utility room and get one of those Q-tips. They're wood on one end and they have the big ball of cotton on the other end. Have the patient just close their eyes, touch them with the sharp end or the wooden end and the cotton end, and just ask them smooth or sharp and touch, and make sure that they can tell you that it's smooth or, soft or sharp or whatever term you want to use. That's the easiest and quickest and most effective way to assess sensation. All right, so here's an image of kind of positioning that person into that letter C, angry cat. You see that the spine is curved all the way around the patient's sideline. You can also have them do this sitting up. They can sit with their feet kind of hanging over the bed and then curve on their side. You have a little better control of the patient in this position. It depends on what procedure they're doing as to whether they need them in that upright position. If they're draining a whole lot of that fluid, they may want them upright because they can do it a little bit better. It will depend, and that's up to the physician to dictate that. So next we have CT, or computed tomography. I'm sorry if y'all can't see all of that because of my image there. I'm not sure. But the CT scan is something that takes 10 to 30 minutes depending on the procedure and the amount of dye they're using, or if they're using dye at all. And the patient just has to lay there in the machine, and basically we take some pictures of them that the physicians can look at and determine what's going on. So things you need to know. A, do they have to have contrast dye? Sorry, y'all. A, do they have to have contrast dye? And then if they do they have any allergies? A contraindication to contrast dye is an allergy to shellfish or iodine. They have similar properties, so please make sure that they don't have those allergies, because it's not always going to say allergic to contrast dye. It might say allergic to shrimp. Well, if they're allergic to shrimp, they can't have the dye. Please, please, please check your allergies. Do not kill your patient, because it didn't say contrast dye, it said shrimp. Remember right now, Ms. Furr told you, shrimp and contrast dye might as well be the same thing. Don't kill your patients. Check their allergies. So if your patient has claustrophobia or gets really nervous, you're going to give them some sedatives or request sedatives as ordered by the physician. Things that are very, very, very important to teach them. They have this nice little thing right here that says contrast dye may cause feeling of warmth. I added or need to urinate because it wasn't there. I want you to know, when you get contrast dye, you're 100% certain that you have just peed all over yourself, all over the table. Everything is on fire, okay? It is weird, very weird sensation. Your patients are going to be extremely uncomfortable. It is not painful by any means, but it is a very weird and uncomfortable sensation, and they're going to be certain they peed themselves. And so you need to let them know this is going to happen. If it does, you're not actually peeing yourself. It just feels that way. And if you do actually pee yourself, it's not a big deal. It happens so much that nobody thinks a thing of it. We'll just clean it up, because there are going to be people who actually urinate because they cannot control what is occurring because the sensation is so strange. So please make sure you teach on that point. So when they get back, we're going to give them some fluids to encourage that contrast dye that we had them take in to be flushed out so that we don't traumatize their kidneys. And then we're going to continue to monitor them for allergic reaction in case that they have anything in response to that dye. So MRI. MRI is magnetic resonance imaging. MRI is also going to be used when looking at the brain, looking at the bony structure there, verifying that we don't have any kind of brain bleed, or that we don't have a compression fracture or the lumbar space getting squished, things like that. So most importantly, number one, make sure there's no metal on the patient. I would love to show you one of these lovely little pictures of a person who didn't realize the MRI machine was on when they rolled a bed into it, and it literally sucks the entire bed into the machine. So think about how strong the machine is. If they have an implant, if they have an artificial joint, if they have a pacemaker, anything like that, if it is not specifically designed for MRIs and has absolutely no metal in it, it will rip it out of their body. Do the checks. New thing I did not know, and I learned the other day, there are magnetic eyelashes. Okay, I did not know this was a thing, and I just learned this, but apparently there's something that you can put like on your natural eyelashes, and then you put this other thing on it, and it like clips to your eyelashes. So when you check for the other 9,000 metal things that people can have in their body, hip screws, been shot before, so they have metal bullet fragments left in them, whatever, please add to your list eyelashes, because it can cause damage to the eye when it rips those off. So new random thing. Sorry, squirrel. So metal, check for all metal. Administer pain medicine or sedatives as needed, because they're going through a loud, rackety thing. It does not take nearly as long as the CT. And then teach them how to relax, slow, deep breaths, things like that, because they do have to be very still. And then there's really nothing to do afterwards except wait anxiously for the results, and they're going to be as anxious as you are. So an angiogram. And just so y'all know, we've kind of moved on through to page 996. They kind of give you short answers on a lot of these, but we're just covering them briefly. So an angiogram is where we're going to inject a dye and actually see how it travels through the blood vessels, especially the blood vessels in the brain and spinal column. So gonna verify that informed consent. We're gonna give a clear liquid diet if it's ordered. We're gonna insert an IV, and the IV site is gonna be specific. A lot of times they're gonna say it must be greater than 18, and it must be in the antecubital AC or higher. And the reason for that is when they inject the dye, they don't want it to go into outer space for a whole long time before it gets to where they want it, because they need to see it right away. And so they'll determine where they want the IV. I'm so sorry, y'all. I'm so sorry. So they're going to determine where they want the IV, and you're going to verify that you have one in that site. And if you don't have one there or higher, you're going to place it. And then as needed, you may give some sedation. And then when you get back, you're going to keep them in the bed flat for 4 to 6 hours, because if they have to access through the lumbar space, then you may need to keep them just like when you do an LP. Keep pressure on a site for 3 to 6 hours. And by site, that means a femoral access site, jugular site, whatever they're doing. If they go in through the femoral artery so that they can go all the way up to the carotid or into the heart, they're going to have a bigger hole with a longer place, and it's arterial, which means it has a lot of pressure. So you're going to put a pressure dressing and keep a weight on there. They have a cool thing that I really, really like now that is not a sandbag, because sandbags are very aggravating, and it is exactly what it says. It is a bag filled with sand, so it can be a little messy. But it was a really cool thing that I really like now. It's like, it looks like an Apple Watch type thing. If they do the brachial artery or the radial artery, you can use it there. It goes around with this little band, and it has an air pocket in it. And then the air pocket has a syringe, and it works like a Foley catheter. Like you squeeze air in with the syringe, and it blows up the balloon and applies the pressure to the artery for you. And then you can go in like every hour and take like maybe a half a cc of air out, so that it slowly releases the pressure over time, which reduces the risk of bleeding. Because when you do the sandbag, you end up just taking it off, and all of a sudden all the pressure returns, and sometimes it busts open. But with this, you can reduce it a little bit at a time. It's a much better invention. I'm just sad I didn't invent it, because now I would be a billionaire, because it's awesome. So take vital signs, check the site, check for pulses, because what did I just say we're putting on here and cutting off? The artery, which is supplying blood. We have these other little collateral arteries, but they're not main ones. So what do we have to do? Check pulses, check cap refill. Please make sure that you don't cut off blood supply to anything else. If you put a sandbag on somebody's femoral artery or their groin, please make sure that their toes are still nice and pink. They're not blue or gray or whatever. Just so y'all know, I'm holding my toes up so I can see them past it off my computer, because I can't talk and not do it at the same time, because I'm weird. So lastly, we're going to encourage hydration, because we want to make sure that we've got less viscous blood circulating, since we're eliminating, we're creating a lot of clotting factors from just having that procedure. So we have the myelogram, and the myelogram they have here is an x-ray of the spinal canal and the contents in it after injections of contrast. This looks for compression of nerve roots, herniation of discs, blockage of cerebrospinal fluid circulation. So we're going to check for allergies to contrast and shellfish. Assess for a history of seizures, because we don't want to increase pressure in that space or alter the pressure in that space if they have a history of seizures. And then verify their consent as well. Similar to an LP, encourage fluids, and then keep the head of the bed slightly elevated after that procedure. And then lastly, you're never going to hear this word again in your life, electroencephalogram. I've never in my life heard anybody actually refer to it by the entire name. It's an EEG. But if you do obtain consent for it and you write EEG, guess what? The consent is garbage. It must have the entire word. So you do have to learn it. Even if you're like me and you can't spell it, you have to at least know what word to Google to verify the spelling on. So electroencephalogram is where they go through and stick stickers all over your head. And those stickers have wires that are measuring impulses that go back to a little hairnet thing with a machine. And this machine is responding to those electrical impulses and telling us kind of like some of your brain activity, commonly used in seizure activity and things like that. And so before you want to do this, you want to make sure that there's not a whole bunch of oil and stuff on the scalp, or if they have a lot of dandruff or psoriasis or dermatitis, anything that's going to leave a lot of flaky stuff that's going to interfere with the electrode replacement. You're going to brush the hair real good, make sure that you get it as clean as possible before you apply those stickers. And then afterwards, you're just going to make sure that you wash the hair, clean the area. You don't want to leave sticky stuff in somebody's hair for days. This is not something that's typically performed by us. We're not always applying those caps and things. That's usually performed by someone specially trained in EEG, so they know exactly where to place them. But it is our responsibility to have the patient prepped appropriately and to perform that aftercare appropriately, because they're not going to do that. They're going to return them to us so that they can start with the next procedure. So why is this stuff important? Why do we do all of this? First off, patients who have had a neurologic event, and if you notice, CVA is cardiovascular, like as a stroke, the words that they talk about now, they use words like event or accident as opposed to, you know, a stroke or a heart attack or whatever. They like to call them cardiovascular events or cerebrovascular events, because they're talking about how something occurred there. And so when these events occur, we need to be prepared as nurses to prevent further complications, because these patients are already going to be frustrated enough and struggling enough, or they're going to have some crazy outlook like CJ's friend who go and yell at her every time she walks down the hallway. But if they don't have control over certain portions of their body because of this neurologic event, it's going to take weeks to months of therapy to get back to where they were before, or at least to their maximum potential now. But in that meantime, if they're not getting adequate care, they can develop complications that are permanent, like what you see here, which is called foot drop. So what happens is there's no sensation or anything telling the foot to stay flexed. And so it just kind of falls flatter and flatter and flatter. And then these nerves and tendons right here, they just shrink up. Like it doesn't ever stretch. So why? It just shrinks up, and then it gets hard and knotty and fibrous, and it's permanent. There's nothing you can do about it. The patient who you see here, even if they do everything for her, she will never walk again because her feet are done. She cannot straighten them out. She cannot flatten them. She cannot bend her ankles. She'll never walk again. So to prevent things like this from occurring from our patients, you've all had the patient with contractures. You've seen them with the hands a lot. To prevent those, we have to do things. Maintain functional positions. Roll up a ball, a tennis ball, whatever, put it in the hand to keep it from being able to contract all the way down. Putting a footboard on, which is something that keeps the foot stretched out at this 90-degree angle. It's got something hard in it. It's got a little strap that runs this way that holds it there. And then you have to take it off and do exercises, range of motion exercise regularly. Prevent contracture, avoid injury, and then mobilize ASAP. So returning this patient to activities of daily living, we're going to encourage independence based on their level, and we're going to increase their level of independence as appropriate based on their therapeutic interventions. We're going to maintain a routine, and we're going to provide assistance as needed. We are not going to do things for the patients because we're in a hurry, because all you're doing is taking away from them and kind of degrading their opportunity to succeed. So communication. We spoke briefly earlier about expressive aphasia, which is the inability to get those words out, and then receptive aphasia, which is the ability to hear and process those words, and dysarthria, or difficulty getting things out or getting them out of order, or maybe formulating a speech. So as you encounter these things, what's going to happen is the patient maybe understands and they know what they're saying, but when it comes out, they've got dysarthria, so the word changes a little bit. So to prevent frustration, because these patients are frustrated, they know what they want to say, but it's not coming out, or they hear exactly what you're saying, but they can't do anything with it. So they're going to become frustrated easily. So let's try to use yes or no questions. We talk so much about therapeutic communication and open-ended questions, and now I'm asking you to do the exact opposite. But this is in a very specific population, and we're only going to do that when we see that that patient is beginning to have trouble or get frustrated. Correct substituted words. So like if they can't remember a word and they just give you something at random, give them the word that they need so that they can start utilizing that and putting it back into their memory bank. Anticipate needs. when you feel like something is coming, go ahead and make that readily available to keep them from getting to the point where they're past tolerance and they've reached that I'm done, I can't get what I need, I can't function, they're done. So make sure you have those available. Use gestures, allow the patient to gesture to you. And then if the patient has that receptive aphasia, meaning they can't process the words and make it make sense, use gestures, because gestures and words are not the same. So use those gestures to point to something. Maybe if you're wanting them to drink, touch the cup and indicate turning the cup up. Give them the indication that you want them to drink, something like that. And most importantly, be patient with the patient. Don't rush them. Give them time to think out what they want to say. Please don't cross your arms. Don't roll your eyes. Most importantly, don't tap. I literally almost came to blows with a resident one day because he was standing there doing this, tapping, because the patient couldn't come up with the words that he needed to say. And he told the patient, "You're delaying." And I thought I might actually kill the man before I asked him to step out of the room. And we had a conversation about appropriate behaviors with the patient. Remember, I told you residents don't actually get to see patients. So sometimes they're only taking care of somebody. It's their third or fourth time. They don't understand the social interactions yet. That patient ended up having a grade 4 bleed, which meant like the entire inside of their brain was actively bleeding and turning into jello, and he was transferred to the neurosurgical ICU at Maine. And so it was a major ordeal, but I was very, very upset with him for rushing the patient. I understand we all have things to do, but I assure you, in this moment, the patient's embarrassed enough that they can't think of what they want to say. You are not helping the process if you delay them or tap or anything like that. So please be respectful. Lastly, nutrition. Every single patient that comes into the hospital has to have a swallowing evaluation prior to care. The reason for that is, as some of you know, Trent and Andrea took care of a patient who had aspiration pneumonia, and they basically said that they have tested her and tested her and tested her, and there's nothing they're going to be able to do to stop her aspirating. Every time she aspirates, she's going to get pneumonia, she's going to get sicker, and it will eventually kill her. And that is very difficult to process for people. But what can we do as a hospital to prevent that? What can we do as a nurse to prevent that? Well, before we give them something to eat and drink, let's test and see if they're going to aspirate. Because if they are, maybe it's just temporary. And as soon as we resolve this neurologic issue, as soon as we get through therapy, as soon as we give the medications, they're going to improve and can go back to their regular diet. But in the meantime, we need to keep them safe. So we're going to evaluate their swallowing first. Once we determine where they are on that spectrum, then we're going to intervene. I personally am not a speech therapist, and it is not in my scope of practice to decide what they need. But Gwendolyn is one of the speech therapists that some of you may have seen at the hospital. She's absolutely amazing. She's probably 6 foot tall. She walks with a cane. She's absolutely wonderful. But if you find Gwen, follow her around one day. She'll teach you something wonderful. But speech therapists, they do have the ability to evaluate that. They have a master's degree. They are trained in studying all of those things. They evaluate what the cause is, and they help determine the plan to make sure the patient is safe. And so if you identify that your patient has slurred speech or a droop, then you're not going to proceed to the next step of giving them something to drink. If you make it through steps A, B, and C, and the last thing that's ordered in evaluating a swallow is to give a sip of water, and you give them a sip of water and then they just cough and cough and cough, then you know that they've aspirated. Their lungs are trying to get rid of it and they're coughing. So at that point, you're going to say, "I'm sorry, you can't have anything else to eat or drink. I don't care what the order says. If the order's for a regular diet, it doesn't matter." You as the nurse are in charge of making that decision. You make the patient NPO and notify the physician and notify speech therapy. And then they're going to come and determine, do they need thickened liquids? Do they need patients sitting upright for meals and monitoring them? Does somebody have to stay with them? Or are we going to have to give tube feeds? CJ's friend, I think, had his tube feed for a little bit and then decided he wanted real food and he was done with it, so he ripped it out. Not best practice, obviously, but it worked for him. I don't understand how or why, but it did. That's not normal procedure. So think about that. Enteral tube feedings may just be a bridge until they get that muscle control back through therapy. So make sure that you're giving your patient adequate nutrition and doing it in a safe way, because obviously nutrition is required for adequate healing. So I know we've covered a ton of stuff today, and there's a lot here, and there's a lot that you maybe do know and feel super comfortable with, and then there's other things that you may not feel comfortable with at all. Please utilize the discussion forum, write down your questions, ask them. When Ms. Springer finishes with your endocrine lecture on Tuesday, I'll be happy to try and answer questions if you have them, and then we'll also do some of the hands-on stuff like discussing more in detail those range of motion exercises, assessment of musculature. We can practice with the eye movement and accommodation, and some of that cranial nerve assessment if you guys would like to go over those to make sure everybody's on the same page. If you don't have any questions for me, that's fine. If you do, let me know. Let me see what I can do to help you, and we'll get you guys on the right track. So thank you for listening to me drone on today, and I hope that you're able to utilize this in the next day or so that you don't have so much in that first portion of the week. You can get through some of this through the weekend. So thanks, guys. Have a good night.